just, I know I'm preaching to the choir. You know that CF is an autosomal recessive disease. It's most common in Caucasians, and the incidence is 1 in 30,000 in the U.S. And that's really putting into account all the ethnic backgrounds. So you know, in the Caucasian population is 1 in 25, in African American and 1 in about 16,000, and in Asian is 1 in 90,000. So it depends. And now there's other ethnic background. I have few patients from the Middle East. When they were diagnosed, I was told they were diagnosed outside of the institution, and I was told they don't have CF. They have positive sweat, but they don't have CF. And the reason for that, and that's from a physician, that they're from the Middle East. Well, they have CF. So, and I have several of them. So, and I'm sure children have a bunch of them as well. The estimation worldwide is really underestimation, because if China doesn't have any CF patients, there are how many billions of people there, so, and they don't test for it. So there are about 70,000 worldwide, but it's really, I'm quite sure it's a fraction of what CF incidence is there. So for the clinical manifestation, pulmonary is the most important, since I'm also a pulmonologist. So it's the primary cause of morbidity and mortality, or the causing symptoms. Having Emily being in the hospital, when she wanted to go to DC, she had to stay in the hospital. And also mortality. And we are very happy that the median survival is 41 years. But as I always told Mrs. Bonnell and the girls, is that I expect them to live normal life expectancy, because they are healthier, they're doing more for themselves, and all the babies that we're diagnosing now should really be living normal life, and that's with all the medication we have. And just going back there, CF patients are colonized with bacteria, and that's why it's very important to do the throat culture every 3 months. A lot of my kids hate it, and I don't think anybody likes it, but it is what it is, right? But we have to treat the infection. So if we have Pseudomonas, we have to be, like, we have the results coming back in 2-3 days, and if we don't jump on it and treat with Toby, then that will be colonization, and we're never gonna get rid of it. That's why when the state changes rules on us and tell us, or the insurance companies, not the states, I have to be specific here, that when the insurance company is trying to save money, even though they're covering Orkambi and Kalydeco, which is thousands and thousands of dollars, and coming to Toby and say, no, you cannot use it, that is unacceptable. So we are really, we're lobbying for the patients, but the patient need to lobby too, because nothing like a face of a patient.
Dr. Nasr, can you, because a lot of people ask me, it's the most common question I get asked is, why is there like bacteria in their lungs? How is that different? Why don't regular whatever people get it, people who don't have CF? So
right.
What can you
So the nature of the lung disease, so you have in the airways, you have very, and I think I might get into that later, there is a very dehydrated mucus. So you have the problem is the chloride channel. So the chloride channel allows the chloride to go in to the cell. It should be staying outside and drag with it the water. So you have really a very dehydrated mucus. The nature of the mucus will really allow the bacteria to go in. First, we get the virus infection, then we get the bacteria. When you have staph infection, then you most likely will have Pseudomonas later on, because it does something to the cell surface, and that would make it accepting the Pseudomonas. These bacteria are very weak bacteria in general, and it doesn't, the normal population don't get it, but the CF patient does. We have it also in the immune deficiency patients, they can get it, but not in a normal people. So that's why CF kids are not infectious. So when they go to school coughing, you don't have to worry about the other kids getting it. The other thing is the staph. When we have MRSA, which is a bad word in the community, it is not the same one that the CF kids get. I have parents calling, crying, because they were told the kids have MRSA, and it's like, oh, you didn't tell us, and what should we do? And it's like, really nothing. So it's very important to educate the families, but it's the nature of the sputum and the lungs that allow the bacteria to get in and stay in. So this is just to show you the kind of progression of the disease. I thought, okay. So you have the inflammation, you have the acute infection, which makes the inflammation worse. That leads in the X-ray to hyperinflation. You might have hemoptysis, which is an automatic admission to the hospital because it is due to infection. You have the mucus plugging, and when the kids are coughing up stuff, this is from the lung. That's why we do the vest, because the vest can move the mucus plugging as well. Then you have bronchiectasis, which is permanent damage to the lungs. So that's why we work really hard to get them to be very aggressive in the taking care of themselves to not get to the bronchiectasis stage. A lot of the time we follow the lung with the spirometry with the lung function and make sure if the lung function is dropping to do something about it. So I'm not only treating the symptoms, because some kids they're minimizers. So they could be coughing and having problem exercising, walking, and they come into clinic and they say, we're doing fine. So I'm looking at the PFT and I'm like, okay, your lung function is low, so I'm gonna treat that. And that's really been very helpful to explain it to the families as well. Digital clubbing is very common, and I remember when I say to families, oh, the baby have digital, or the little child have digital clubbing, they get really anxious about it, and what we're gonna do about it? Nothing, is part of the disease. So again, and it's because of the oxygen going to the beds of the nail beds is decreased, so you end up with clubbing. And then the last stage, which we really don't wanna get to, is the respiratory failure and the lung transplant. So, and luckily, I haven't sent anybody for lung transplant from the pediatric center in ages. So we used to a lot of this, but because they've been doing better, we haven't been doing that. So this is just to cover all the other organs, because CF doesn't affect only one organ, which is the lung. It affects the gastrointestinal tract. So you have a lot of kids with the bloating and the greasy stools, and these are because of the pancreatic insufficiency. Their pancreas is not working well. That leads to the steatorrhea and the meconium ileus, which is really very important. To me, if any baby have meconium ileus, it's CF, still proven otherwise. And our surgeons have been very good in that, and they usually contact us. Because with meconium ileus, you might have negative newborn screen. So now we have newborn screen since 2007, but if you have meconium ileus, you most likely will be negative for it. So I know in Grand Rapids there was a case of meconium ileus that was jumped on as CF, and we have cases as well in Michigan. There are some other symptoms. I'm not going to bore you with all the symptoms, but these are all the things. Failure to thrive is very important, and we work on it really hard. We have a algorithm and a plan for this, and we've been doing it for years. We actually published it. And our BMI data, or body mass index data, are really still very good. And it's mainly to train. I'm big on QI. I do a lot of quality improvement work, and that was one of my projects that I involved all the physicians and the nurses and everybody. My key to quality improvement work is the staff, not the physicians. Actually, the physicians don't listen to me a lot of the times. I nag them, but but the nurses, if I want something done, the nurses, the social workers, the dietitian run with it. So they've been running with the quality improvement for the body mass index for years. Now we're doing the CF Rise, which is a transition preparing program, and the social worker is running with it. She's doing a great job. So, and then we just notify the physician, we're doing, so and such, and that's fine with them. Some patients are pancreatic sufficient, so their pancreas is okay, and these are the ones that are missed with the newborn screen. These are the ones that are diagnosed later in life. We just diagnosed a 10-year-old, and that was missed. Well, he was before the newborn screen. It's very important to me because I'm involved in newborn screen quite a bit. But all of these organs are involved. We have CF-related diabetes, so we screen the kids when they turn 10. We screen them for this, and it's a pain, and nobody likes it, and the kids hate the cola that they drink. But I usually tell them, well, you know what? It is what it is. You have to do it. So, and kids have been good about it. Now, to treat CF, you have to understand the basic defect. So for us, we know there is obstruction, we know there is inflammation, and we know there is infection. They're born with normal lung. But once they are born, the process starts. They're born with normal lung because they are breathing through the mouth, so they really are not using their lungs till they're born. So once they are born, we know the process starts. So to treat it, we look at obstruction. So what I do with the babies, brand new baby, a week old, looks beautiful, everything looks good, and I would talk with the parents and I say, we're gonna start with the bronchodilator, albuterol or whatever you need, twice a day regularly, and you're gonna do airway clearance twice a day regularly. And the babies, we do it by hand, so it's kind of hard for the parents, but, and that's before I see any symptoms. And I usually tell them, don't expect to see anything. It's mainly preventative. It's to kind of clean as you go. I usually start Pulmozyme first, but with these new guidelines, I really have to fight for it because now they're asking us to do hypertonic first, then Pulmozyme, which is not the way I do it. I do Pulmozyme first because Pulmozyme, you don't have the extra cough with it. It's easier for the kids to take, and they tend to be doing well with that. Now, hypertonic I add when they start having more coughing or infections or things like that. It's irritating, it makes them cough more, and some kids just don't like it. Well, I think everybody doesn't like it. But, you know, especially with babies, and if you get them fighting you over something, I might lose that. So I cannot do it for a period of time and then get back to it. So that's why I always use the Pulmozyme first. Then for inflammation, we really, we don't use ibuprofen. It's one of the drugs that caused a lot of side effects. The idea is good, but it's not really effective for us. But we use a lot of inhaled steroids. And that's mainly to make sure to bounce back on their lung function. And then we're lucky enough that, since the CF gene was identified in 1989, which I remember that vividly because at that time I moved from Children's to U of M, and I remember the hoopla and the excitement about it. Since then, we had Pulmozyme specifically for CF. We have tobramycin specifically, the Toby for CF. We have Astrinum, we have Zithromax. All of these are specifically for CF, which never happened before. We didn't have any of that before. So that was very exciting. So this one shows you the survival over the years, and it shows you the medication that we have. So every time there is a new medication, you can see the improvement in lung function. Pulmozyme, the Astrinum, no, this is the Zithromax, sorry, and then inhaled steroids, hypertonic saline, and CF modulator now that we're having, which is really another excitement. So it's really important. We also used to, in the 80s, 70s, 60s, we used to be less aggressive treating CF. I remember I was told that in the 60s they would do low-fat diet because the enzymes weren't too effective. So the kids would be starving. Low-fat diet, and so now with the enzyme coming to the market, no, we need high-fat diet, high-calorie diet, but the calories are in the fat. So everything in this curve added to allowing us to treat CF more aggressively, and the payoff is the median survival.
Dr. Nasr,
yes.
Was being more aggressive, was that simply a change in a mindset of the medical community, or was it really some of these additional tools that led to the medical community to be more aggressive?
That's a great question. So what happened in the 70s, early 80s, before I got into CF, there was a great study done by epidemiologists from Toronto and from Boston. And what they did, they compared the weight of the patient and the PFTs. Toronto was known at the time to be more aggressive in pushing calories versus Boston, low calories, low fat, and the kids were all like thin and not doing that well. And they compared the data and they realized that high calorie is a lot better than low calorie, and your patient does well. So at that time, it was like a revolution in the care. So all of a sudden, all of us decide, and then the enzymes were available as well. So that was actually a turning point. And then since then, we've been more aggressive in treating. And you go to the CF meeting, and the CF families are actually very savvy. they talk to each other. We know that the underground network that you guys have. So they talk to each other, and they also wanted more aggressive treatment. So that's making a huge difference. But yeah, the study from Toronto and Boston were the turning points. And please stop me at any time. So this is just to show you in more details of when the medication came to the market. So for any medication to come to the market, we have to go through studies. So you have to go through phase 1, phase 2, and phase 3. And phase 3 is the bigger number of patients, and then that would allow us to have, if it's positive, then the FDA approval comes after that. So before actually the TOBI, there was the Pulmozyme, and that was my first study. Actually, I was a fellow at the time to do. The enrollment started, and it was like a military system. It's like within a month, they got like 800 patients. Because all the patients are you guys are very educated, you're with us, you wanted to do things. We were getting calls. Are you doing the study? Okay, we want to be part of it. So we didn't really recruit. People called us. And it was a study that everybody got in and done as quickly as we can, and we got the approval. So that was very exciting. And that's really the other plug I want to put in. Participating in studies is very, very helpful, because that will allow the drug to come to market sooner. So please, if you get contacted about any studies, remember to not say no. These kids are not guinea pigs, they are pioneers. So we need more pioneers. But this just show you all the studies that came out recently, and we've been really busy. I have one full-time research coordinator, a 75% another research coordinator, and a third one. So we've been bombarded or busy. So it's actually very good for the patient and for us. So now, how to treat CF is another thing. We used to just treat CF. We have a protocol and we apply to everybody. Then we moved into personalized medicine, which is, each patient is different. So Emily, I know what she does and doesn't do. She wasn't very adhering. She looked like she was, but she really wasn't. So you have to work with her, and you have to be able to communicate with her. I have other kids that are more severe, so I have to communicate with them, and you have to try to just connect. That's very important, because if you connect with the patient, then they might be able to do more. But now we're getting into actually precise, which is really neat. So personalized is, we do the throat culture, we see where we are with the organism they are getting, we look at the lung function, we help see what we need to do for it. But precise is to be more accurate and exact in your treatment, meaning looking at the mutations, looking at the disease severity. So this one, so when you look at the severe, now with the modulator coming in the market, the Orkambi and the Kalydeco, how much of the CFTR, of the CF gene, you want to correct to be able to get milder disease? And a lot of studies were done, and they showed that if you have 30% of the CFTR function, you should be having milder disease. The more the better, because if you don't have anything, you have severe disease with pancreatic insufficiency and lung disease. And then the pancreatic sufficient patient, which are milder, are about 30 to 40%. And you get back to, if you're normal, you're 100%. If you're carrier, you're 80% CFTR function, but you don't have symptoms if you're a carrier. So that was really important, because would it be 5%, 10%, 100% improvement, and that would affect the working on different medications. So no CF talk goes these days without showing the categories of the mutation. So each patient have mutations, and two defects that happen, one from mom and one from dad, that cause the disease. And every time there is a pregnancy, there is 1 in 4 chances of having CF. So now when we do the mutation analysis, what group or classes the patients are in, and that really help us when we're designing studies for the patient. So if you're class 1, this is the worst because there is a stop codon or stop thing on the gene that makes it not expand, and I'll show a beautiful picture coming up. Now, the class 2 is the CF, the delta F508, the most common one, and most patients are in this class. Delta F is not the only one, there are others in that group, but it's the most common one. And then you have class 3, you have class 4, class 5, and there is class 6 that are much, much milder. And so the most severe patients are in class 1, and it goes down as you go on. And the incidence of how many patients nationwide is right here. And it's specific to the US. So now you're seeing this is the channel. So I'm gonna go back and go to it again. So see, this is the middle of the cell, the nucleus, and that's where your CFTR or the CF gene is produced. It goes out into the cell and then go to the surface of the cell. And that is your chloride channel. The chloride channel, or normal people, opens and closes normally, so that way it's an active channel. So allow the chloride to go in and out as the body demand or as the lungs demand. In CF, it's a different thing, and that's what the gene is. The gene is really the cell surface, and that what allow the different bacteria to grow. So when you're going to okay, all right. So for class 1, the process in the cell, in the nucleus, is not really complete. So you don't have anything going outside at all. So you would really need a lot of help in that class.
So my daughter's obviously inherited one gene from her husband. Is it important that I get them tested to see which gene they inherited to determine? Like they have mild asthma, they just need like an inhaler for soccer, they have no other symptoms.
If she's a carrier, then you don't need anything.
I mean, like this was just, I thought this was referring to like if you're a carrier, you only have one gene.
No, if your carrier have one gene, you have nothing. You have no symptoms. You're just, your CFTR or your gene function is at about 80%, which you only need like 30, 40% to be able to, yeah. So no, carriers, you don't need to do anything with them. Right. So this one, you can see class 1, you have a problem here from the start. Class 2 with the delta F508, you have it produced, you go out into the cell and it kind of dies in the process, so it doesn't make it to the surface. Class 3, it goes to the surface, but then there is blockage, so the channel is not really working well. Class 4, it just, again, doesn't work very well. This one, there is blockage. This one just doesn't work efficiently. This one have less number of channels on the cell surface.
So on that, so the girls have the second one, delta F508, and something else, which I can never remember.
It's the
So
third one.
what is it?
I think it's the third one.
Oh, okay.
That's what you said last time.
So when that medicine that I think is in trials now, that'll help them in the future, right?
Right. So, and I'll go on to the, that will show later. So
if they have children, are they more susceptible to passing that on because they got it from both parents?
So if they got married to a non-carrier,
Okay.
all their children will be carriers. That's it.
I'm a non-carrier,
So make sure whoever you marry to is not a carrier. Minor detail.
But truly, can you, I mean, so
Can you
How about
find
that
out
for
from
the first
that?
Is something that is awesome that going into a marriage, people can, I mean, not that you would not get married, but.
Right, so you can have the screening, which is the 23 mutations. It's not covering everything. Everything is about 2,000 mutation and about 160 is disease causing. If you have one of the 23 mutations, that if you marry that person, then that would be the most severe, like if you have CF kid. But if it's outside of the 23, even if they have CF, it's not going to be as bad. So that's something to keep in mind. So the screening that the OB group does, and you can do it earlier if you want. You don't have to do it at the time of trying to have babies.
My brother had his, after the girls were born and we didn't know we were carriers, my brother and his wife got tested right before they got married, just so they knew
Yeah.
and they.
Right.
To be honest, I feel like that could stop CF.
Yeah.
Just put that, everybody to bed.
Exactly. But also,
I'm sure it's very expensive. I'm just saying, stop it, you know?
there is a lot also of, I mean, if you're willing to spend the money, there is also a lot of in vitro testing, and that you can actually select the sperm that doesn't have any CF mutations, and also maybe choosing the other mutation, not the delta F508, which is milder. So there is a lot of new technologies that you can do that. It's expensive.
Is there a certain age that is better for testing if you want to know you're a carrier? Is there an age?
So
that's
no.
recommended, like some?
So we for all the CF kids we genotype them because we really want to know because of all these drugs coming up. For family members, actually, we have a very generous donor that we established a gift account for him. And if any of our patients wanted to be family members, like the uncles, the aunts, or whoever wanted to be tested, then we can do that. I have grandparents wanted to be tested, and I said, why? But it made sense because then if I know the grandparents what mutation, then that side of the family I can only test it to that mutation, which would cost me less money because I'm funding it. Yeah, but we have that program that we do, and it's been nice to have it available. But there is no age. I mean, you can. So if there is a sibling, like by definition, you have to sweat all the siblings once you have a CF patient. And you can do the mutation analysis. You still have to do the sweat, but you can do the mutation analysis so they know what mutation they have. So, so now get to the new medication that we're having. The ivacaftor was the first, and or the Kalydeco. So, and it was the first one tested in that category, and it's mainly a potentiator. You have a problem that you have the gene going all the way to the cell surface, but it's blocked. So the channel is not opening. So you wanted something to open the channel. So that drug is a potentiator, meaning he potentiates the effect of the cells of the channel at the cell surface. So it was tested on CF patients with GG551D, and that's what it does. It's like, without the drug, it keeps going up, the chloride keeps going up, and it doesn't go anywhere. But if you have this thing here, which is the Kalydeco effect, then it opens up, and I'll run it again so you can pay attention. So see, you don't have anything going through the channel, but once you have this little thing here, then you're having a normal channel. Yeah, right, very, very interesting. The results of this study was amazing, and it was actually gave us all like goosebumps. I mean, I have patients on the study that were coming in, Emily, not you,
Yeah.
the other famous Emily, and she was just going crazy about it. Actually, during the study where we didn't know if she was on the drug or not, she was blogging all over the place saying that she's on the drug. I didn't know, but apparently she felt it. And that we can see here, and pay attention to that because it's coming in the, or can be, you're gonna see the improvement, not as much. So you see improvement in the lung function by 10%, and it was sustained through the study. So it happened really quickly, and it continued on. So within the first 2 weeks, you got into improvement by 15%. And this is from all the patients that were enrolled. So that's huge.
Is there lung capacity or?
Lung function, yes, yeah. So we usually, if any drug increase the lung function by 4 or 5%, we're very excited. This is like 10%, and it continued through it. The other one too is that the patients were healthier, so they stayed healthier better than the patient that did not take the drug. So that made a huge difference. So this is no problems at all. And then as the study goes, you still have a little bit of a problem, but it was about 67% of the patient have some breathing problem, respiratory problem, infection, and versus the placebo that was a lot more. So that was another thing that the FDA looked. That was the fastest drug, this one and the palmozine, approved by the FDA because there was no question. I mean, you have it. Look at it any way you want. It's improvement. So there is no problem with that. So after that, then the G551D is 4% of the patient. There is 1%. Other patients that's from the same group, the group 3, that were not tested. And so we did test them. So that's the non-G551D mutations, but they were all in the same class 3. We also tested it in the younger patient, the 2 to 5-year-old, because I don't want to start it at 6 and above. I want to start as early as I can, so this way you can prevent the long-term damage. And also the R117H mutation is in the class 4. And that one, the patients are very mild. So I have one patient or two on it. And it's good, it's keeping them healthy, but it's not a gangbuster like the G551D patient, because these kids are milder anyway. But I am putting patients on the R117H if there is the specific indication for, in my mind, that I would do. So that covers class 3 and 4. So now we're going from the ivacaftor only for the G551D in class 3, so now you're expanding it to all the gating mutations. So now we're at 5%, and you're covering class 3, 4, and 5. So that's good, but these are 15% of the patients. So we wanted to cover really more of these patients. So the delta F508 is the most common, we all know that. And there is about 45% of the CF patients that are homozygous, meaning delta F508 on the 2 mutation. That's what you thought the girls had. And then the 39% have delta F508 and other. And then there is the other, the 14.5. So we wanted to target more patients. And that led us to the study that we finished, and actually we had the approval for the Orkambi. Orkambi is a combination drug. Remember that delta F508 is produced in the nucleus, in the middle of the cell, and then it goes to the cell, and then it dies in the cell. It doesn't make it to the cell surface. That drug, so you need actually 2 drugs. One of them is to correct for that and make sure it goes all the way to the cell surface, and then the other one is to potentiate or make the channel stronger. So you need 2 drugs, each one of them have an action or mechanism that works. So that was very important, and that's why when we tried the Kalydeco on the delta F508, it did not work, because you don't have any channels going to the cell surface. And the improvement in there, and that's what I would like you to see, the improvement, only 3%, not really that much significant, but these are overall patients. You really have to remember individual patients react differently. So, and then also there was decrease in the patients without the event, without any problems. They were a lot better than the patients that were in the placebo. They got the approval from the FDA on that. It was a lot harder to get approval for this one than from the Kalydeco, because the Kalydeco was very simple, very easy to approve. And every time they go to the FDA, they actually take patients with them. And the patients will share their story. I don't think they did that for Kalydeco because they didn't need to, but for this one they did. And that's powerful. When you show a patient that tells you, I felt better with the drug, this is huge. So very important to be active. Advocacy is a huge thing in CF. By the way, that's why the CF is approved for life with Children's Special Health. It wasn't by accident. Parents went there, we had lawyers, and they tagged along and they got it done. Sickle cell didn't do that. There is a lot more sickle cell than CF. So it's all about advocacy. So in summary of this process, you have the airway damage, you have the thick secretion, you have the airway infection, and you have the inflammation. And it's like a cycle. It's like the chicken and egg. What comes first? And to me, it doesn't really matter. I have the patient I have to treat. So for airway damage, you want to be able to assess it in a good way. Just X-ray is good, but not really that great. So CT scans are very helpful. Sometimes we do bronchoscopy to just see what bacteria they're growing. And just to finish this part up, you have the anti-inflammatory, you have the antibiotics, you have the hydrator, which is hypertonic saline or the salt water, and then you have the mucolytic or the pulmozyme, and now we have the modulator. CF gene therapy is not really there yet. They're still working on it. So the ongoing research, just a few words about that. So now we know that the lumocaftor and the ivacaftor do not work on the delta F 508 and other. They don't. We tried it in phase 2 and it didn't work. So they cannot really use that for it. So but what other things we can do? So the ivacaftor and the lumicaftor are the first generation of medications in that group. So now there is second generation, there is third generation, which would be more effective. The other good news is that a lot of drug companies are getting into it and they're getting excited about CF. Now remember, it's only 30,000 in the country, so they can't get their money back for all that. That's why Kalydeco and Orkambi are so expensive, because they're trying to recover a lot of the cost of the research. So now we have something called VX661. VX is for Vertex. So there's a bunch of studies we're participating in, and I'm sure other centers are as well. And that's to try the ivacaftor, which is very effective, we know from class 3 treatment, and the G551D. Trying the ivacaftor, but combining it instead of the lumicaftor with the VX661. And trying it on patients with delta F508 homozygous, with delta F508 and gating mutation. We're trying it with CF patients with the dysfunctional problem or function but not effective. So there are a bunch of studies going on right now, and it's the VX 107, 108, 109. I mean, I wish there's other ways to identify the studies. So, but it's VX, 108, like there is a lot of numbers. And in Michigan, I think between the 3 centers, I don't know about Lansing and Kalamazoo, but between the other 3, us, Children's, and Grand Rapids, these studies have been done in Michigan, all of them. And if we have a patient that qualifies for a study that we don't, or we're not doing the study, then we refer them to another center. And the CF Foundation is encouraging that tremendously. The foundation is actually giving money to cover the cost of preparing the patient to be transferred to the centers. So the VX661, it works with a similar mechanism to the lumicaftor, which is a corrector, but it's better, it's stronger, it's longer half-life, meaning you take it once a day or twice a day. So it's really very helpful. And this is, I'm sorry about the slide, it came dark, but when they compared the lumicaftor, the Vertex, the VX661, so it showed that, as you're going to different groups, it improved their lung function versus the lumicaftor that didn't do as much. So it was tried in all the different groups of patients to make sure is it effective, should we do it? And this is really part of the preparing for a study. You have to show the FDA in phase 1, phase 2, and then you get to phase 3. So all of these, the companies are working, or the sponsors are working with the FDA, so to make sure that it's safe for the patient to participate. So now we covered class 2 with the Orkambi, with the Orkambi, 3, 4, and 5 with the Kalydeco. How about this one? This is the troublemaker mutation. There is a problem in the nucleus, in the middle of the cell. So to include that, so this one, did I go too fast? Okay. So this one is also animated, and it shows you was working yesterday. It actually is a read-through, so it's something that actually was working really well yesterday. What it is that this is part of the gene that's produced, and then this is the read-through, which is to translate the gene into the structure that you can go into the cell. And it goes through, and then there is a block right here down the line that actually breaks it down. So you cannot have, that's why it breaks down in the cell, in the nucleus. So the new drugs, and I'm sorry that didn't work. Okay. The new phase that we're working on is to try to, there is a new drug called Atelurin. Atelurin is a drug that is really work on trying to read through and get you the full gene, and that can go into the cell surface. So there is some improvement. There is a lot of work on this. We realized that improvement wasn't that great. From here, the lung function improvement, not that great. But then they realized that if the patient are on TOBI, that would interfere with Atelurin. So they're now trying it with people that are not on TOBI or gentamicin. And this is the one that I'm talking about, that, you know, with no inhaled antibiotics, mainly tobramycin or gentamicin. In other countries, there is a nice improvement, versus the one on the inhaled antibiotics, there is no improvement at all. It was tried in Israel, and in Israel showed a lot of improvement versus here, and here because most of our kids are on TOBI, so that was the difference. So the gene therapy story, we're still going. It's been still on trials in the UK and I think France as well, trying different scenarios and different ways to do the gene therapy. It's still in the works, but I usually tell my kids and my parents, so who cares? We'll work with whatever we have, and just make sure, CF is there. It's there every day. You're not going to get rid of it. So let's be wise and make sure it doesn't really affect your life that much. And I understand there is a lot. So this is another animation to show you how this one you're reading through, and this to create the gene, the normal gene. And this is how the CF gene looks. So these are in the cell surface. So this is really what the channel is, open and close, and then the other three pieces are down. So this is how it looks like, and these two would be down in the cytoplasm, in the cell itself. So now if we can have all the pieces get together, and this is the delta F508 mutation. And then we wanted functional genes. So to have a functional gene, you have to have different pieces to add to it. So I think there is another animation. Okay. So now you have the delta F508 right here. So how do you compensate for it? So again, knowing the structure of the CFTR or CF gene is very important, and knowing where the defect is very important to try to target it. So there is the next generation CFTR corrector, and I talked about the VX661, but there is a lot of others going on. I am part of the Cystic Fibrosis Protocol Review Committee. There's a lot of protocols coming to the foundation. So what happened is, for any study, you get the protocol submitted before you get to the CF community. You submit it to the Cystic Fibrosis Foundation. It's called Therapeutic Development Network, which is the research branch of the CF Foundation. And then we review the protocol. We have nurses, physicians, and statisticians with us. We review the protocol. We make sure the protocol is feasible and makes sense. Actually, I have patients as well on the review committee. And we review it. We give our input back. The sponsor usually listens to what we have to say. And then we approve it, and it goes to the patients. So the process to get any study to CF patient is really not just a sponsor come in and say, let's do a study. They don't do that. They have to go through the foundation, when the foundation is very protective. So again, for the CF TR, for the delta F508, so here, it might take one corrector, and then there will be another corrector, second corrector. This is really the ideal situation. So to have two correctors to make it stronger, and then that would help move the gene into the cell surface. Because we realized that the lumicaftor wasn't strong enough, well, we're thinking maybe two of them need to be added. So for CF, it's like climbing Mount Everest. I went to the base camp. It was a great experience. I did not go to the top, but just base camp. But it's really good. So at base camp, you identified the CF gene in '89, which was exciting and was really great at that time. Since then, actually, the CF meeting, it used to be like 500 people going, maybe 1,000. Now we're having 5,000 people attending, which is really very exciting. Then you have the classes. You identify the classes, because it's very important, because if you're going to target your treatment to be precise, you really need to know what the classes are. Then you have the ivacaftor, you have the lumicaftor, ivacaftor, and now we're having the other ones that we're working on, and the idea is we need to restore the CFTR function for all mutations, not only for one. So that is very important. And I think that is it. So the idea is to identify the gene, to know what exactly to do with the patient, and follow up the patient clinically as well. Thank you. I usually have a picture of the girls in there, but I decided to have them. Sorry. Yeah.
What is, before we break off in the other section, and Leslie, welcome. CF mom there. What is the biggest challenge for you as a doctor with all your patients?
Well, the biggest challenge for me that I want the drugs to be available for me. So when the Orkambi came to the market, when the Kalydeco came to the market, we did a lot of preparation to the state. And usually when the state, when the Children's Special Health approves something, most likely the other insurance companies will approve it. We worked extensively with both Blue Cross and with the state, and Dr. Eggleston and the Blue Cross. We give them a lot of guidelines of because the drugs are expensive. So they're like, okay, we're gonna let you have the drug to give to patients if, and they give us parameters that made no sense. So we really had to work with them. We had to pull a lot of data. The same thing for Orkambi. It was really hard to get approved. And we worked a lot with the insurance, gave them a lot of literature to make sure they understand not all CF kids are the same, and you cannot tell me, well, if their lung function get better by 10%, it's okay, then you're not being realistic here. So we really didn't want them to hold us accountable with one thing. It's personalized. So working with the state is very important, but now I'm getting all these ridiculous things that I can't give Toby to a new colonization. So my most challenge is to have the drugs available to be able to give to patients. My second challenge is working on improving adherence, because a lot of the kids, especially teenagers, they don't want to hear about it. And I have one of my kids, he said to me, I don't think about CF every day. Well, that's the problem, because if you don't think about CF every day, you're not doing your treatment. No, I want you to think about it every day, but not to limit you and not to paralyze you, but to remember that you have to do your treatment. So that is very important. And from parents' side, you really need to encourage your kids to take care of themselves and to do the treatment. And there is always, I love this, reward and the punishment thing. I mean, some parents come and say, well, he doesn't want to do it. Well, really? He has a phone right there. Can you do something? So it's very important to work together here. And sometimes I offer for them to come to my house, and then I'll take care of them.